of you have probably seen, many of you have probably attended other sessions with the other RHSC IMs, diving into the LEAP report data. And this is the last of those, really focused on the contraceptive market. So we're very excited to dive in. Just before we do, if Michelle, you could maybe just move the slides on, I would just like to introduce myself. As I am the new co-chair of the MDA working group. And I would just like to talk a little bit about who I am, so you know who I am, and also just a little bit about what you can expect to hear from MDA Working Group over the next few months. So hi, everybody. My name's Abby Winskill. I am currently a project director with PSI. I am a Brit, but also a Canadian. The accent, I think, is still British for the most part, but you can tell me. And I live in Canada, so just in Quebec. So it's a very cold winters, but some lovely summers. I have been with PSI for about 8-9 years now, and I am a project director working in the SRH space, primarily on contraceptive innovation and self-care. And before then, I worked for over 8 years in the commercial sector at Unilever, working in business and marketing. So I do come at this very much from sort of with a commercial sector mindset, but very much then transitioned to the public health sector. My particular passion points, I am very much about user insight, market insight, and how we use user insights, market insights to design people-centered programs to shape markets, particularly for innovation, in order to increase access, choice, and ultimately market sustainability. So if any of you ever want to reach out and chat about any of those things, please do. I'm always happy to connect. And the reason that I applied for this position of co-chair, I have two main goals, and hopefully you'll see more of this as we go through together over the coming months. But the first one is I'm really passionate about the concept of the MDA working group and its ability to bring together experts working across all different areas, but really bring together the power of that experience and that knowledge to solve sticky challenges and to overall increase our impact. I think too often we work in silos, and too often the sector doesn't know what the sector knows. And so I think that really bringing people together to share that knowledge and to solve some of the really sticky challenges that we're all facing, I think is very powerful. And secondly, and we'll talk more about this in a second, my goal very much is to figure out how, as a network through the MDA working group, that we can deliver tangible value to you as the community of practice. So we want to see, really be able to define a few areas where, as a network, we can really deliver value to everybody who's in this space. So that's my goals. Just to talk a little bit about what that's going to look like over the next few months. So Michelle, if you could, there we go. So where are we now? So you may have noticed, I hope, that this is the first MDA working group session for a while, where there hasn't been one for a long time. And that has been for several reasons, not least of all because there has been the recruitment happening for the co-chair. But we do know that the MDA working group has a strong reputation. Many of you on this call have been here for a long, long time. But also after the RHSC conference last year in Ghana, we got a significant number of new members as well. So it has a strong reputation for really bringing people together in the sector, and a large membership. But it has been dormant for the last year, and the MDA working group is not as active as some of the other implementing mechanisms under the RHSC, and that's something that we'd like to change. In addition to this, the RHSC is currently developing a new strategy, and so this really gives us an opportunity then to think about how we can reignite the MDA working group, how we can refine the focus, and how we can bring the network together under the new RHSC strategy. So in order to do that, in November, we will set up a collaboration session for all of the MDA working group members. In that session, we will be sharing the key strategic pillars from the RHSC's new strategy. It gives us, then me, an opportunity to learn then about member interests. So it's going to be a very open session where we really want to hear from everybody what your interests are, what your needs are, and where you would really like to see the MDA working group focus. And then we'll really brainstorm ideas collectively for the value that the MDA working group can bring. So that's going to be a session that we're going to have in November. Alongside that, we're going to try to have some in-depth discussions with some subgroups. Obviously, I think a lot of the people who are members of RHSC are in implementing partners, but we also have donors, we have manufacturers, we have government stakeholders. And so we'd like to really hear from them as well about what they would see as value coming from the MDA working group. All of that then will feed into an MDA working group work plan, which will be based on the member priorities. Will integrate all of your ideas and obviously really pulled together under the RHSC strategic plan. I say with the available resources, we don't have a huge pot of money, but I do think that there's some tangible value that we can bring to the community of practice and to further the RHSC strategic plan. And that will also bring then ideas for activities and learning sessions through 2025, 2026. So that's where we're going. So I will stop here for now. And just to say that I really invite you and anyone you know who is a member of MDA Working Group, who would like to be a member of MDA Working Group, to join us in November so that we can really brainstorm together the collective power of this group and really come up with a really strong work plan through 2025, 2026. And the final thing I will say is that I am the new co-chair. I would really like to have another co-chair though. Right now it's just me. So I would really love to have a friend. I have Natinda and Nadile and Sarah, but I'd love to have another co-chair friend. So we would love to have, and we'll be putting out another call for co-chair very soon, and would really love to have somebody come on board by the end of the year. So if you're interested, or if anybody else who might be interested, please do reach out and let us know. Please feel free to put any questions in the chat on that. But in the interest of time, I'm going to hand over to Michelle to really dive into the LEAP report findings for the contraceptive market. Thanks, everyone.
Great. Thanks, Abby. And I'm glad we could get the MDA working group back together for this session today. So I'm just going to jump backwards for a second to briefly look at the agenda, and also just to note that we're going to be doing a few polls on Mentimeter today. I'm just dropping a link into the chat, or there's a QR code there that you can use just to get a little bit more interaction from the group. But we're also a pretty small group, so hope that we're going to be able to do quite a bit of just people talking and using the chat to engage as well. So the plan for over the next hour, a little bit less, is to just give an overall introduction to LEAP, to focus on some key results from contraception, to do a little bit of a deep dive into looking at some variation that we see across different income groups, regions, and countries. We're then going to introduce 2 new data explorer tools that were released after the LEAP report launched to allow more access to the data, and then save some time at the end for questions and answers. So as we go, if you have questions or comments, please drop them into the chat. So before we get into talking about LEAP, we wanted to just do a quick Menti to get a sense of how familiar people are with the results. There are no right or wrong answers. We just wanted to get a sense of how much this community has already been using LEAP to help us kind of think about how to steer the focus of today and also think about more opportunities in the future. So I see a couple people have voted, but we'll give it another minute or two for others to join the Menti and be able to add their votes as well. And hopefully that link is working. And if not, you can go to menti.com and enter the code that you see at the top. All right. So, oh, the results are updating, but not, very strange. Oh, there we go. Okay. Thanks, Lucia. Okay. Great. So we've got a nice distribution there with some people who have used it, some people who are a little bit familiar, and some people who are not. So we hope that today provides a good overview for everyone. Great. So LEAP encompasses 4 different health areas. So in the 2021 report, we made a big expansion. So the The predecessor of LEAP was the commodity gap analysis, which focused just on contraception. But in 2021, we expanded out to cover menstrual health, abortion impact, and maternal health supplies as well. The focus in 2021 was really building out those new health areas. So for contraception, we updated the data, but we didn't really make any big changes. And so this time around for 2024, we kind of brought our focus back to contraception, and we're able to introduce some changes into the contraception analysis, which we'll talk about today. And while LEAP presents these 4 different health areas separately, the results are interconnected in sort of the back end of the LEAP modeling. So for example, changes in contraceptive use influence the need for maternal health and abortion impact services, and also the use of hormonal contraception influence our menstrual health results by looking at sort of a reduced need for menstrual health products among women using methods that reduce their bleeding. And so again, we look at these results all separately, but they are interconnected behind the scenes. So across the 4 health areas, we look at similar results. First, we look at the people needing and using key reproductive health supplies. We look at the quantities of drugs and supplies used, and then the cost of those drugs and supplies. We look at a current landscape, which for the LEAP report is 2023, and then we project forward to the future out to 2035. We do the analysis for 132 low and middle income countries. And for some of the results, these are then segmented into the 3 country income groups defined by the World Bank. So low income, lower middle income, and upper middle income countries. We use a wide range of data sets for LEAP, as you can see here. Anything shown in yellow is a new piece of data or new data source that was integrated in for LEAP 2024, and other data sources were updated where relevant. So for example, capturing new DHS or mix or PMA surveys that had come out since last time we did the report, or picking up new projections from the UN Population Division. Some of these new data sources, we'll come back to this a little bit later, helped us get more visibility into prices in the private sector, both for contraception as well as some of our other health areas. And that included some work we did in collaboration with Maisha Meds, and I saw Dan is on the call with us today, as well as some work we did to look at some online pharmacies in select countries and pull prices for various products from those to get a little bit more price information where we had some limitations on that. We also changed how you engage with the report. So LEAP now has 2 main reports for each health area: an overview report, which is a dynamic report that can be viewed for any selected country or region, as well as a global GNI comparison report. And this report really focuses on differences between low, lower middle, and upper middle income countries. There are also 2 data explorer tools, which we'll come back and talk about a little bit later today, as well as annex tables and just downloading all the results. So lots of different ways to access the data depending on what your interest is and what you're trying to get out of LEAP. So with that, I'm going to go over some key results for contraception. For this first bit of results, we're just going to focus on the overall aggregate results across all low and middle income countries. Excuse me. So we estimate that there are 744 million modern contraceptive users living across low and middle income countries. Sterilization is the most widely used method, and about 60% of users obtain their method from the public sector. And you can see that judging by the difference in the height of the 2 bars on this graph, which show the total number of users in the public and private sectors stacked by what methods women are using. We see pretty distinct differences in the method mix among public sector users and private sector users, which we can see more closely if we toggle this graph into relative view, which all of the graphs in the LEAP report allow this toggling between absolute and relative. So here we see that within the public sector, the vast majority of users are using long-acting and permanent methods, while the opposite is true within the private sector, with nearly 70% of users relying on short-acting methods, namely condoms and pills. We estimate that there was $548 billion spent on contraceptive supplies in 2023. This is largely driven by pills and condoms in the private sector. One note I wanted to make about a difference in the LEAP 2024 report as compared to 2021 is we changed how we value condoms in the private sector. So in previous iterations of LEAP and the commodity gap analysis, we had used private sector pricing for most methods, drawing on a range of different data sources, but our condom data was a little bit more sparse and quite variable. And so we had made a decision that given that sort of uncertainty, we would just use a public sector price for condoms, even within the private sector. But this year, with some of the new data sources that we were able to access, we felt that we had enough information to introduce a kind of true private sector price for condoms in the private sector. So you'll see that our estimate of the supply cost associated with condoms has increased significantly compared to previous LEAP reports. For this LEAP report, we also did an additional analysis exploring a little bit more the emergency contraceptive pill market. So when doing some consultations ahead of the LEAP 2024 report, this came up as a key priority for those in the community, recognizing that LEAP is missing some of the emergency contraceptive pill market because LEAP is built starting with contraceptive use from CPR, from surveys that ask women about what they're currently using. And we know that a lot of EC use is not picked up through this question. So there are women who are using EC who don't really get captured in this metric of CPR. And so there was an interest in trying to explore to what degree we might be able to add this into the report. So for this time around, we weren't able to fully integrate this into LEAP, but we're able to do sort of a side analysis, and the results are presented in a box within the report. This was done through a partnership with Maisha Meds, again, as I noted earlier, using some of their import and export data to look at volumes of EC. We purchased data from IQVIA on commercial sales volumes as well as price of EC in a number of countries. And we also utilized data that was in the contraceptive social marketing statistics. And we put all this together to try to estimate the size of the EC market. And we estimate that while we captured some EC in LEAP, we were missing quite a lot. And so we estimate that there was about $330 million of supply costs not being captured within LEAP. So again, this is not included in the slide you saw before. This is sort of additional. And we hope in future iterations of LEAP to explore how to better integrate this type of analysis into the main report. Looking ahead to the future, one of the big changes for contraception this year was introducing 3 future scenarios. So in the 2021 LEAP report, for the new health areas, all of them included future scenarios. We had the reason for including these was that there was sort of a less clear direction of travel for those other health areas. And there were some really pressing questions in the community about changes in product use. And so having future scenarios let us explore those to sort of provide information about what might happen under different contexts of change. In the past, for contraception, we had used the median trajectory of changes in the number of contraceptive users, which we still use now. And we had just explored a scenario where method mix changes informed by recent patterns of change. So we kind of looked at how method mix is changing across different regions and assumed that those method mix changes continue. For this year, rather than doing that, we wanted to really bring in the idea of future scenarios, and after consultation with the community, we kind of coalesced around creating scenarios that explore different roles of the public and private sector. So in our first scenario, we just maintain the sector mix, so kind of nothing changes, so the number of users increase, but where those users go and the methods that they're using do not change. In the second scenario, we looked at a shift towards more public sector use. So what if the share of users going to the public sector doubles with some constraints put on that? And for our third scenario, we looked at the opposite. What if the share of users going to the private sector doubles? for these last two scenarios, we kept the method mix within each sector the same. So looking at the implications of what would happen if more women went to the public sector and the methods that they got in the public sector mirrored what women are getting now. We know that there could be changes in the future that could allow access and use of different methods within each of these sectors, but we thought that this was a useful starting point to help inform discussions. I think it's important to say that these scenarios are not meant to be predictive, but rather to provide information for the community to inform some of the dialogue that's going on right now about the potential shifting roles of the public and private sector, and in particular with an eye to the implications of those shifts in terms of method choice and in terms of costs and potential kind of cost burden on users. This graph shows the change in contraceptive users by method across the three scenarios. So we see in the orange line that even with no changes, the number of users grows just due to increase in the number of users due to population growth and growth in MCPR across countries. We see that with an increase in public sector use, as shown in scenario 2 in the teal, that we see more rapid increases among long-acting and permanent methods, as well as injectables. And in contrast, under scenario 3, where we see an increase in private sector use, as shown in purple in this graph, we see much more rapid increases in pills and condoms. These changes not only have implications for what methods women are using, but also big implications in terms of supply costs. So these, with an increase in public sector use, there would be a decrease in supply costs, decreasing by 3.11 billion or 57%. And with an increase in private sector use, there would be a large increase in supply costs, increasing by 4.42 billion or 81%. And without changes in financing mechanisms, this supply cost increase in the third scenario would largely come from users paying out of pocket for their supplies. And finally, on this slide, we can see what is driving those changes in supply costs, and almost all of the changes are being driven by pills and condoms. These methods are quite expensive over the time, right? If you take account to needing multiple pill cycles and multiple condoms over the course of a year, they are kind of relatively more expensive than other methods. And there are also methods where we often see large differentials in the cost of these methods between the public sector and the private sector. So this is really what is driving those drastic changes that we saw on the previous slide. So the results we just looked at were all looking across all low and middle income countries as a whole. But of course, there's wide variation across regions and countries that are covered within the LEAP report. And so now we're just going to take a little bit of a look into some of these regional differences. So first, if we look across income groups, we see large variation in the method mix. So these graphs show the method mix among all users overall in the first graph, among public sector users and among private sector users, each bar representing one of the income groups. So the first bar is low income, the second bar is lower middle income, and the third bar is upper middle income countries. We see variations in method mix. So for example, in the public sector, we see that in low income countries, implants and injectables play a large role, where by contrast in lower middle income countries, sterilization plays the largest role, and in upper middle income countries, IUDs play the largest role. We also see some variation in the private sector, especially for low income countries, with a more kind of diverse method mix within the private sector in those countries. The roles of the public-private sector also vary across income groups. So this graph, the width of the bars represents the share of users that are in each income group. And then the split between the orange and the purple, kind of within each part of the bar, shows us the relative role of the public and private sectors. So we see that across all three income groups, most users get their method from the public sector, but the role of the public sector diminishes from 70% within low income countries to just 53% among upper middle income countries. When looking at this graph, it's important to remember that this graph represents a snapshot of current countries and doesn't imply an inevitable path that as countries' income increases, that we will see this shift from the public sector to the private sector. The picture we see today is driven by policy decisions, often in just a few large countries. And if we look at other health areas, we often see a very different picture where we see a resurgence of the public sector in upper middle income countries, the sort of shift from donor-supported public sector in low-income countries to more government-supported public sector in upper middle-income countries. And so while it's useful to look at this picture, I think it's also important that as a community, we challenge ourselves to think about sort of different futures and what those could look like and how financing could be in place to ensure access. So we just looked at how things vary across income groups. LEAP also lets us look at how things vary by region. So here we're just looking at results for 3 selected subregions: Sub-Saharan Africa, South Asia, and Latin America and the Caribbean. Across these 3 regions, we see differences both in terms of the relative role of the public and private sector, which we can see by the difference of the height of the 2 bars. And we also see differences in terms of the methods used within both sectors. So again, kind of different pictures with a very high use of sterilization in South Asia, mostly driven by India. In Sub-Saharan Africa, you see that large use of implants and injectables in the private sector, and a more varied method mix in Latin America and the Caribbean. We also see variation at the country level. So here we've picked 3 countries. These are all lower middle income countries in Sub-Saharan Africa. So even if we look at countries that share both a geographic region and are in the same income group, it doesn't mean that things look the same. So here we see large differences, both in terms of the roles of the public and private sector. So Senegal with almost no private sector use versus Cameroon, where the private sector is larger than the public sector, as well as differences in method mix within these countries. And so again, I think the aggregate LEAP results are important, but it's also useful to remember that they hide a lot of variation across regions and countries. We've mostly been looking at results for for users, but I thought just quickly it would be useful to look at results in terms of supply costs, as there are stark differences when we view the market in terms of users versus when we view the market in terms of costs. So on this slide, we see contraceptive users by method on the left-hand side across income groups, which we saw earlier. And on the right-hand side, we look at a similar picture, but rather than looking at users, we look at costs. And what we see in this is that while upper middle income countries account for the largest share of users, this income group is much more dominant when looking at costs. We also here, as we saw earlier, see the much more pronounced role of the cost of pills and condoms relative to the use of those methods. And so I think looking at the market in both ways is really important and can tell us different things. So before we continue, I just wanted to pause and give an opportunity to hear from the group. So we've seen a lot of variation in terms of use and cost across regions and income groups and countries. And so just wanted to take a moment to get ideas from the group of what might be driving these differences. So we'll let people go back to the Menti. Hopefully it will update this time as people put in responses. And if you're having issues with the Menti, you can also just put your responses into the chat as well. All right, the slide seems to be, there we go, lagging behind. All right, so you see differences in insurance coverage, differences in needs, pricing policies, different types of investments, norms. Another one on cultural norms, the role of the public and private sector. Great. Yeah. So I think it's, these markets look very diverse across different places for lots of different reasons. And I think it's, LEAP tells us a lot about the what, but not the why. And I think it's useful that we just keep these different things in mind and think about them as we talk about potential for shifts in the market, for interventions that could help address potential market failures or make markets more accessible, that we think about all of these different contextual pieces. Great. So with that, our last segment today, and then we'll open up for questions and answers and discussion, is to take a quick look at these two Data Explorer tools. So first, there is a country comparison Data Explorer tool where you select a region and are able to compare results across countries. Oh, sorry, and that did not get updated from the menstrual health. The number of users, the methods they use, and the costs. And then the product deep dive Data Explorer, where you can select a single contraceptive method and see detailed results across that method. So first, let's take a look at the country comparison Data Explorer tool. So for this one, there is a drop-down list where you can select a region or group of countries. This drop-down list includes income groups, geographic regions with two different kind of splits, a more aggregated one and a more detailed one, as well as some different donor priority country groups. So for today, we're going to take a look at the Ouagadougou partnership countries, and you'll see when you select a group, there'll be a box that tells you which countries were included within that. So here we're looking at users by method across countries within the Ouagadougou partnership. You can interact with this figure in different ways. First, as we saw earlier, you can toggle between absolute and relative view to see the number of users versus to compare the method mix across these different countries. And we can also change what indicators we look at, looking at costs versus users and looking at a select sector. So for example, here we're looking at costs in the private sector across these different countries. The second figure in this section lets us look at the roles of the public and private sectors. So here we see the relative share of users going to the public versus private sector in each of the different countries. So in this graph, we see that in Togo, the highest share of users go to the private sector at 44%. And we can toggle this graph into absolute view to look at the number of users. And here we see that in Côte d'Ivoire, the largest number of users are going to the private sector. And so both of these can be helpful when thinking about markets and different perspectives on markets. This graph can also be viewed for costs and viewed for any selected method. So right now we're looking across all methods, but you can look for any of the methods that are included in LEAP. We can also look into the future in this comparison explorer tool. So here we're looking at changes. So each dot represents a year from 2023 to 2029 to 2035. And you can look at changes by indicator, by method, and by scenario. So here we're looking at changes in implant users under the scenario of increased public sector use. And you can see some quite dramatic increases in implant users in some countries. And here we're looking at the same information, but looking at the scenario where private sector use increases. So here we see the increases in users are more modest given this scenario and the changes that this scenario implies across countries. Finally, we can compare a 2035 endpoint across the three scenarios. So in this graph, each dot represents a scenario. And then you can use the drop-down list below the graph to look at different combinations. So here we're looking at users of all methods in the public sector. And the three dots, again, give a comparison of how many users there are in 2035 across the three different scenarios. And we can also use these drop-downs to explore different iterations. So here we're looking at the cost of condoms in the private sector across the 3 scenarios. And again, we can see some pretty large differences between scenario 3, where private sector use increases in purple, and scenario 2, where public sector use increases in teal. So that is a quick overview of what is in the comparison tool. And now we'll also just end by taking a quick look at what is in the product deep dive tool. So for this, you can pick one individual method. So here I've chosen implants as an example. So in this first map, we look at the current landscape. So here we're looking at the number of implant users across all sectors. You can also use the drop-down lists below this graph to look at different indicators, so users, quantities, or costs, and to look at different sectors. So at all sectors, the public sector or the private sector. There's also then a map that lets us look into the future. So here we're looking at the change. So this is the absolute change from 2023 to 2035 in users across all sectors under scenario 2. You can toggle again to look at different indicators, to look at different scenarios, and to look at different types of changes. So for example, here we're now looking at the cumulative quantities of implants. So how many implants would be used between 2023 and 2035 under the increased public sector scenario. So just to wrap up, I want to reiterate that there are lots of different ways to access LEAP results. So again, the overview report can be customized for any selected country or region. The data explorer tools that we just looked at provide even more access to the data. Throughout the report, any graph can be downloaded either as an image file or a CSV data file. There are key annex tables available for any selected country or region. And finally, the full data set can be downloaded for those who want to do additional analysis or visualizations on their own. And so we've really tried to make the information available in lots of different ways. So I have one more Menti for us, and then we will open up to questions and discussion. So just wanted to get a sense. We know that people use LEAP in lots of different ways. And so wanted to just ask the group about how you maybe either have used LEAP in the past or think you might use LEAP in the future. And if you have others besides the options here, please do drop those into the chat. Our Menti seems to be updating now. All right, so lots of votes for understanding regional patterns of use. A few for market sizing, for budgeting and planning. I was going to say, I'm surprised we don't have any advocacy uses coming up, but see one now for advocating for investment. Great. Well, thanks everyone for your participation in the Menti. And with that, we wanted to make sure to leave time for questions and answers and discussions. I see Megan already has a question in the chat, but if other people have questions or even just thoughts, please put those in and we can use the rest of our time together this morning to discuss. So Megan asks if I can speak more about the future scenarios and the assumptions. Yeah, so essentially within each country, we take the method mix within the public sector and the method mix within the private sector, and we assume that stays the same, but then we just sort of shift users between the sectors. And so what that means is that the overall method mix shifts to be more like the public sector method mix or more like the private sector method mix under those two different scenarios. So we recognize that there could be interventions in place that might sort of, for example, might promote more access and utilization of long-acting methods in the private sector. That could mean that, right, we live in a future where the method mix within the sectors look different. But for this leap, we're, attempting to say, if we don't have those changes, if we don't put in supports either in terms of finances or other things, what would the world look like if we saw shifts between sectors without changes in method mix? Megan, I see your hand is up. I don't know if you're able to unmute and speak.
I just changed the settings, Michelle. She should be able to now.
Perfect. Great.
Amazing. Thank you, Sarah. So yeah, thanks for that clarification, Michelle. And that's super helpful to hear what it does and doesn't do on sort of method specific future. One of the things I remember being really excited by was an analysis that you did maybe 5 or 6 years ago. And it turned out to be a really nice advocacy tool. And so I just wanted to run it by you and see if you thought that the LEAP data as it's currently, exists within this interactive report could be used in a similar way, which is to kind of look at how those possible future scenarios around, an increasing use in the public sector in particular might actually demonstrate how overburdened public sectors could become in pursuit of their, meeting family planning goals. So I remember one you had done with SHOPS where it was looking at actually the number of users you would now be driving towards the public sector, especially for long-acting methods like implants and IUDs, would necessitate an incredible growth of healthcare providers, tools and equipment, commodity, et cetera, that actually a lot of countries are not quite prepared to meet. And so it ended up being a nice way to talk about, well, this is a potential reality, and yet maybe it's time to kind of bring the private sector in a more intensive way so that we don't run out of resources on the public sector side. So anyway, I just wanted to put that to you and see if you thought that was sort of a similar thing that could be extrapolated out of the LEAP report.
Yeah, I think that second scenario of an increase in public sector use aligns well to that. LEAP only goes as far as saying how many users there would be, but I think you could extrapolate from there to look at what that change in users within the public sector might mean in terms of capacity and need for healthcare workers and other resources to support those shifts in use. I see Abby asks about any major shifts since the last report. Yeah, so one thing LEAP doesn't do is sort of look backwards at time trends, and we try to limit how much we compare between previous LEAP reports because of other changes. I mean, the main thing we will have picked up this time around are just some new country surveys, so a little bit of newer data on method mix and source mix and level of contraceptive use. But the picture overall looks fairly similar. So I don't think between the two reports, there wasn't the new data that was incorporated in did not sort of drastically shift the overall picture of use, both in terms of the roles of the public and private sectors and in terms of method mix. And I think, a lot of those things are fairly slow to change. So when we're only picking up a handful of new data points between the two reports, we're unlikely to see too many big changes. They're asked if there's anything that was surprising or jumped out in the data. I think the EC analysis, I think we sort of knew we were missing some, but didn't have a great sense of how much we were missing. And so I think being able to put all that data together to look at what was missing was really enlightening and yeah, kind of surprising of just how big of a market there is of EC. And we think that even with what we've been able to put together, we're probably still underestimating. And yeah, so I think that was kind of a new insight for me. The Abby's observation. Yeah, I think Abby, what I, like per unit, right? The price is often low, but then if you annualize how many units you need over the cost of the year, right? It's a little bit like a cost per CYP, essentially, right? So an implant has a high upfront cost, but because it lasts for a long time, that cost is sort of amortized over multiple years, whereas for condoms and OCs, you need multiple units of them every single year.
So it was crazy to see how much that cost is shifting towards the users, right, as well.
Yeah, for sure. And some of that, at least, right, in upper middle income countries in particular, right, the unit cost of OCPs and condoms tends to be fairly high, right? And just you have so many units that even just sort of a small cost differential gets multiplied out by quite a lot. So I will say we didn't get into it today, but that Brazil, the market in Brazil covers a significant amount of that upper middle income pill cost. Though Brazil has recently, there are subsidized pills in the private market in Brazil, and we actually got data from IQVIA that let us capture that. But there has been a new government policy moving to expanding access to free pills to more people. So maybe in the future we'll see some shrinking of that market if that policy implementation really works to translate into women being able to access free pills. I see a question from Christina about other types. So we are, as much as we can in our different data sources, we are capturing different types of oral EC. So in the IQVIA data, we are capturing both LNG and UPA. I'd have to look back at some of the other data sources. I don't know offhand to what degree they're capturing different types of oral EC, all still oral, like moving into other like IUDs will get more complicated in terms of how we know what is EC versus not. But I think we're pretty expansive in terms of capturing oral EC. A question from Gracie about EC and additional data we hope to collect in the future. Yeah, I think, between the data that we are able to get from our collaboration with Maisha Meds and the data we're able to purchase from IQVIA, we have a pretty good coverage of the market. But are probably, there's, I would say, some kind of blind spots in that in terms of parts of the world where we might be getting a little bit less. And so thinking about what we might be able to do to make sure we're kind of getting more of that data. I think price points for EC, we know there is big variation. And so we're doing our best to capture what we think is sort of a representative price. But within markets, there is huge variation in how much products are being sold for. And so I think getting more into that price and getting more data points to help us better understand that price would be really helpful for thinking about the value of that market. think we're a small enough group too that if folks want to unmute to share any questions or just observations or thoughts, we've got a little bit more time. There's a question about registrations. I might that's kind of out of my scope, but if there's others on the call with thoughts about the future of product registration and implications of that, or
I would just say in my limited experience with this, I don't think it's going to get any easier, unfortunately. I also think that there seems to be an increasing focus on WHO pre-qualification as a prerequisite to product registration, which, while that's a good thing in terms of a greater focus on quality, I think that sometimes there are additional hoops that are not necessarily necessary to jump through when there are already bioequivalent studies or already other evidence available. So yeah, I think it's a great question. I think it impacts access and competition in the market in the private sector as well. But I'm not convinced in the next 3 years that we're going to see anything particularly different there, unless anyone else disagrees. Or should we wrap up, Michelle? We've got about 5 minutes left. Thank you so much. That was really great. I love seeing the information laid out in this way. And in case you missed it, Sarah put the link to the portal in the chat. I personally have just bookmarked it. So it's now a favorite in my, so it's just a click away, and I would encourage others to as well. I think if you have any other questions, there's the notes on the chat here. Thank you so much, Michelle. I know this is your 4th presentation to the RHSC IMs, but really fantastic as always. And just thank you to everybody for joining. And as per my plug at the beginning of the session, please do join us for our collaboration session in November, where we can really brainstorm together what value MDA Working Group can bring to the new, under the new RHSC strategy and to the community of practice. So thank you very much, everybody, for your time.
Yes, thanks so much for joining us. And if you do have more questions, you can email at that leap@rhssupplies.org, and that will come to me and some others on the team. So always happy to answer questions and get feedback on the report.
Thanks, everyone. Take care.
Thanks, everyone.